Good morning or afternoon. My name is John Barrows. I am the President and CEO of the International Eye Foundation, and it is my pleasure to be the chair of Vision 2020 USA. Vision 2020 USA is a member organization of 47 organizations with a common interest in promoting vision and eye health in the USA. Today's webinar, Building Better Systems for Pediatric Eye Care to Advance Health Equity, is Vision 2020's first webinar in 2022. We want to start a discussion on access to eye care and the social determinants of health and advocate for improving our services. Today's webinar is moderated by Dr. Kevin Frick, a frequent contributor to Vision 2020 USA, who will introduce three excellent panelists. This webinar will be recorded and available on the Vision 2020 USA website. Over to you, Kevin. Thank you.
Thank you, John. And it is my pleasure to be moderating this session with three wonderful panelists to speak about the issue of building better systems for pediatric eye care to advance equity. We have with us today, and I'll introduce them and then they can say more about themselves when we go to the first question. But we have Dr. Megan Collins, who practices here. We have Stephanie Klas, who is a parent of children with vision issues. And we have Dr. Ruth Shoge, who practices at Berkeley. And we're going to begin by, first I'm going to make sure you can see our panelists better. And we will begin then by having each of our panelists give them a little introduction and share with us what got each of them interested in pediatric eye care generally and health equity issues in this space in particular. And I'm first going to ask Stephanie to comment on what brought her to this topic.
Hi, thank you very much to Vision 2020 USA for inviting me here to participate in this webinar on pediatric eye care and health equity. I'm honored to be here to share my family's vision story with you. I'm going to share a slide with you. Just get started. It's dark, isn't it? Just give me 1 second. Oh, goodness. My apologies. There we go. There we go. So again, my name is Stephanie Klas, and I am a middle-aged Caucasian woman. I have short, medium brown hair, and I'm wearing a dark gray shirt with long sleeves. I'm presenting from home today, and the background of my screen is a blurred image. On the screen right now are three images. On the left is a picture of my son, Brandon. He's a young adult male with dark brown hair with a buzz cut, and he has sunglasses on the top of his head. On the right is my son, Hunter. He is also a young adult male with short, dark brown hair, a little longer. He has on a blue polo shirt and has a bigger grin on his face. In the middle of the picture, there's the three of us standing by a wooden sign that says Old Trace, and there are fall trees and grass in the background. Our story began back in 2004 at Rainbow Preschool. My oldest son, Brandon, was 3 years old at the time, and his teacher suggested I take him for a vision exam as he was holding his books and toys very close to his face. I remember noticing this at home, but never really identified it as a problem. It had never interfered with any of his developmental milestones. After his appointment and some extensive medical testing, he was diagnosed with bilateral optic nerve atrophy. It was genetic, not correctable, and they were unclear about its progression. His acuity was about 20/400 bilaterally, and thankfully it hasn't changed up to today. Our vision journey had begun. Brandon's life has been impacted in so many ways. Learning to be successful in school was a huge challenge. Brandon cannot read print books, see the chalkboard, or use a pen and paper. He reads using a minimum 48 font size, but prefers audio learning with text-to-speech. He got his first desktop CCTV, which is a large electronic magnifier, in first grade, and later needed a portable one. By third grade, we had introduced a computer for him almost full-time to give him a chance at keeping up with his peers. This became his main method of reading and completing all of his academic assignments. He had to teach many teachers how to use technology, as it was still uncommon to be used in the classroom back then. Over the last several years, his iPhone has literally become a lifeline, allowing him to participate in about any task. He uses it to navigate airports, buses, or walking around town. He enlarges materials with it. He reads signs, set timers, alarm clocks, all of which are tasks that are difficult to do visually. He can even access a live visual interpreter to assist with other visual needs that he encounters. Growing up with significant low vision, which is not immediately apparent to others, requires constant creativity, persistence, and determination to participate in everyday activities that others take for granted. Medical forms, menus, price tag, currency all require technology or help for him to access. Many sports are dangerous without sight. I remember him coming home and telling me the gym teacher insisted that he play dodgeball, and of course, he got hit in the face. Crowds and new environments are hard to navigate, and people will think that he's rude when he doesn't wave back. Many emotional and psychological impacts can accompany vision loss. Not being able to drive was a major loss of independence for him. He has struggled with anxiety at times, and most recently, during his job searches, it's been discouraging to not be considered simply because he has no driver's license, or employers are uncomfortable considering accommodations he might need. But where there is a will, there's a way, and Brandon has managed to be very successful. He's finishing his senior year of college and working on finding his first career job. The setbacks and challenges over the years have made him a very strong and determined young man. My younger son, Hunter, was diagnosed just 2 years ago with keratoconus at age 18. This is a condition where the cornea bulges into a cone shape and affects your vision. His condition had advanced quite quickly, and it did not help that he had been 6 months late for his annual eye exam due to the pandemic. It's still amazing to me that even though I consider myself pretty knowledgeable in the vision arena, I had never really heard of keratoconus or realized that it's usually detected in the early teens or early 20s. His vision is also 2400 in his worst eye, but thankfully he had access to a cross-linking procedure to stop the progression and a specialized contact to partially correct his vision. His experience really underscores the importance of early detection and especially access to treatment options, because they can both literally save sight. So my interest in pediatric eye care and health equity is obviously a direct result of my children. I'm extremely thankful that my husband and I had good health insurance and the resources to ensure our boys had excellent medical care and access to the tools they needed to be successful. So many others are not as fortunate. Poor eyesight presents lifelong challenges and can greatly affect personal success, quality of life, mental health, job prospects, and so many other things. Public education and early detection programs are essential to mitigate avoidable vision loss, like Hunter's, and having equal access to vision care and technology will allow individuals like Brandon to reach their full potential and lead fulfilling lives.
Thank you so much, Stephanie. That was wonderful to hear. And I recognize that you gave a description of yourself and the image, and that was quite important, something we should all learn from to do more frequently. I won't give a whole description, but I am a middle-aged Caucasian male wearing yellow reading glasses, sitting in my office today as I am part of this group. So next I'd like to go to Dr. Ruth Shoge, and if you could share with us what got you interested in pediatric eye care.
Thank you, Kevin, and thank you to Vision 2020 for the opportunity to speak with everyone this morning, and good morning to the attendees. Following in Stephanie's footsteps, I'll describe myself as a Black, I guess I can say middle-aged now, but I present younger. How about that? Female with natural hair that's in braids right now. And I'm wearing glasses. And my journey into pediatric optometry started at the age of 6, actually. And so from that age, or since that age, I knew I wanted to be a doctor. And I knew I wanted to be a pediatrician. I wanted to take care of kids like me. And so naturally, my parents encouraged that vision for myself. And it wasn't until I got to high school that I started to learn more about the different health professions, and did an internship with a local optometrist. And that's really when I decided I wanted to go into optometry. And by the time I got into optometry school, I learned I could actually specialize in pediatrics. So my clinical practice includes doing comprehensive pediatric eye exams, as well as binocular vision evaluations, evaluating any learning-related vision disorders or concussion-related vision disorders. And treatment includes vision therapy and other non-surgical therapeutic effects. So that's how I got into pediatric optometry. Where I started to pivot into health equity. And really, when you take care of kids, you're naturally part of a public health outreach, so to speak. It's hard not to be when you're in a pediatric field. And so, doing vision screenings and going into schools and, doing back to school night as part of the educational opportunity for kids and parents has kind of always been part of my portfolio. But I don't think I really understood then the kind of service that I was or we were providing at the time. I went back to get my master's in public health because at that time in my career, 10 years in, I did really want to better understand the patient aspect of healthcare, and what we're missing in terms of who's presenting into the clinic and exam, who's coming in for follow-up visits, why these healthcare disparities continue to persist. And so that's really where I wanted to focus my learning and my incorporating that into my clinical practice. So that's how I started to get more into the health equity slant of things, is through that additional education. And, in particular, really harnessing bias and bias awareness, as well as how we're educating our future doctors. So I continue to work in an academic setting at Berkeley, and I am their Director of Diversity, Equity, Inclusion, and Belonging. So I get to continue to carry out some of these missions and passions that I have on the health equity side of things. And then, of course, still engaging with the pediatric population. So that's a little bit of my story and how I got to where I am today.
Thank you. And next we'll turn to Dr. Megan Collins, and I'm sure there will be some overlap, particularly on the education side of, and not surprisingly, in terms of what gets people interested in pediatric eye care issues.
Well, Kevin, thank you. Thanks to you and John and Vision 2020 for the opportunity to participate today. I am also begrudgingly accepting that I'm a middle-aged female. I have brown hair with specklings of gray in it, also begrudging about that. I'm wearing glasses, and I'm coming to you from my house today, which smells like burnt muffins because I tried to multitask and make some blueberry muffins before today's presentation. So really happy to be here. In terms of my sort of journey into pediatric ophthalmology and into health equity, as Kevin mentioned, I am a practicing pediatric ophthalmologist here at the Wilmer Eye Institute at Johns Hopkins. And my background, even before actually coming into ophthalmology, was in philosophy and medical ethics. And I was really interested in issues of health equity and the doctor-patient relationship and patient education and informed consent. And when I came to Hopkins, I actually was encouraged to get my master's in public health, which brought in, the entire public health side that Ruth was referring to, that often comes hand in hand with a lot of our work in pediatric eye care. When I came to Hopkins, I was also encouraged to do research, which is kind of a classic Hopkins thing. And one of my projects was called the Baltimore Reading and Eye Disease Study. And as part of that project, I actually got to go with one of my optometric colleagues, Josephine Away, into Baltimore City schools. And we would go into schools and do eye exams for kids in the schools. And I have to tell you, I mean, since being in grade school myself, I had not been in a grade school. And I was not from Baltimore, so I was not familiar with the neighborhoods of Baltimore. And it was really a privilege, but also really eye-opening to have the lens of going into the community, into the classroom, seeing kids where they were being educated, where they were living, because it's very different than sort of the lens of when somebody comes into your clinic. It's sort of like coming into your house versus going into their house. And I was struck by sort of the massive number of kids. You know, Stephanie talked about her two children having some very serious eye problems. But I was struck by actually the number of kids who had really common things. They simply needed glasses, and they didn't have them. And sometimes they didn't even know that they needed glasses. Sometimes they had glasses that were incredibly outdated. And this was sort of the start of a lot of work our program has done to actually bring eye care directly into the schools. And I began to appreciate sort of this intersection of education and vision and public health, and how important it is for people to work across these often siloed areas to think about, you know, how do we help kids? How do we help kids where they are? How do we help them not only be able to see better, but also to learn more in the classroom so that we improve their entire life trajectory? So that's just a little bit about sort of what brought me into this space in the first place.
Thank you. And Megan, I'm going to actually follow up immediately with you. All three of the responses initially involve lots of information about eye disease, information that could contribute to our understanding of health equity issues related to eye conditions. And I've had the opportunity to collaborate directly with you, Megan, and I know we work with lots of data. And there's lots of things that you mentioned even in your answer, thinking about, you know, the school outcomes and the access, and what one piece of data, or maybe a small number of pieces of data, do you think would be most important to help us move the discussion and any advocacy or actions we would have to take with respect to health equity forward from your perspective?
It's a good question. It's a hard question to answer with just one piece. I would actually probably organize it into three big buckets. I think having more data, you know, and some of it is doing more research, and some of it is harnessing existing research about the impact of vision on a child's developmental and academic trajectory. Everything from how does having your vision corrected improve your performance in school, to your likelihood to get a driver's license, to your likelihood to play sports, your sort of your employment trajectory, all of those things. Because we all say how important vision is, but surprisingly, there's not that much data that convinces people, other than the kind of core group of stakeholders we have here, that not every national agency or national priority says, you know, kids have to have their vision screened or kids have to have eye exams. And I think having some of that data would be more convincing in that realm. The second thing is, I think it would be, you know, first is impact of vision on various activities and developmental trajectory. The second is what's happening. You know, what is happening in vision screening in different states across the US? What is happening with access to eye care after vision screening? What is the likelihood of having care utilization? Does it matter if you are in California with Ruth or in Baltimore with me? Because we know that there's such marked variation in terms of whether vision screenings happen in pediatricians' offices and Head Start programs, in schools, but we don't really know exactly what happens in every single state, where that variation exists and where there should be some consolidation. And the third would really be kind of reaching out to do some qualitative work in the community to understand, if people aren't accessing eye care, why are they not? Is it that they don't know they have a problem? Is it that they are mistrusting of providers? Is it that, you know, is there something else that is causing that disconnect there? Because when there are services available, it's really important to make sure that people have access to those services. And even as Stephanie talked about, you know, there's so many things that it sounds like she and her family had to advocate for resources to be the advocate for their children, and understanding sort of what do people know and what do they not know and what resources would help them. I think that would be sort of the third area.
Thank you so much. That covers a lot of ground, but I'm sure that our other two panelists would have something to add. So, Ruth, how about you, from your perspective as a provider working in a slightly different part of the system? But what do you think would be most important data-wise to help us move this discussion and advocacy forward?
Yeah, thanks for the question, Kevin. I think that as Megan mentioned, just having data across the different states so that we all know what we're doing and communicating adequately about what the issues are in the different communities and how best to solve them. And, when working with communities, we really need to make sure that we're including them in this process when it comes to data collection. And that's, that can be a much broader topic than what we're talking about. But in regards to eye care, really utilizing community-based participatory research so that we understand the actual needs and the expectations of members of the specific communities that we're working with. And so with that data collection, we also have to ask ourselves and make sure, are we giving that information back to the communities? And that often, gets lost in the shuffle. We collect it, we hold on to it, we analyze it, we publish on it, but are we actually utilizing it and providing tools to the people from whom we've collected that data to actually integrate that information and move forward in making vision care needs better and making access better. So I think a big part of that is one, the data collection, but two, the utilization of that data and then turning it back over to the communities with resources to help implementation.
That's a great answer, and particularly thinking about the importance, as you said, we're not just collecting the data to write about it for our peer-reviewed publications. We're collecting the data to inform those next steps and give it, not just hold it in ourselves, but giving it back to the community. That's really important. And so, Stephanie, as a member of that community of people who need to access care, is there something you think would be most important for you to have as a parent and someone who is perhaps in the advocacy space? What would be best for you in terms of data to help you move forward?
So I thought a lot about this question because obviously it's not something that I am intricately involved in or have a lot of experience with. So I'm going to take a little bit different bent, a little bit higher level. And I wanted to share an advocacy project that I was fortunate enough to participate in last year and how it related to data. So last year I was involved with an organization called Prevent Blindness and a program that they have called the ASPECT program. And ASPECT stands for Advocacy, Support, Perspective, Empowerment, Communication, and Training. So this program brought together parents, individuals with vision loss, clinicians, researchers, a whole variety of practitioners and participants to have a dialogue around brainstorming initiatives, anything related to vision and eye health. And part of that program, we got taught about formal advocacy and telling our story. So with that, I had the unique opportunity to participate in Eyes on Capitol Hill, where we got to advocate with congressmen and representatives in Washington for increased funding for the CDC's Vision Health Initiative, which I wasn't familiar with before. This initiative's goal is to collect data, and that data they want to use to improve the CD surveillance efforts for different social, economic, environmental factors that all contribute to healthcare disparities. So only when that data is collected can the CDC really effectively collaborate with our states and our communities to make all those strategic changes around detection, intervention, prevention efforts, and all sorts of things like that. After this year's work that we did, I was happy to report or hear that the legislation was passed to increase the funding for this year. And if you look at the CDC's Vision Health Initiative website, it's an amazing trove of information, or at least it was for me. So while I can't tell you all the types of data that are needed, there is a lot, obviously, but without this comprehensive data that I was happy to hear was being collected, those changes would be difficult. So I just wanted to kind of highlight my experience with that and my learning around the whole issue of data, and helping move it forward.
Thanks. And that's actually, I'm also fortunate to be familiar with the Aspect program, and that aspect of storytelling. We need our anecdotes because that really makes it personal, but we do need those data to really help bring those stories to life and to help to illustrate how big some of these problems are. In addition to data, obviously we, are all probably thinking, what could be that next big step, either for the practice of care or in terms of policy, that again could help us to move forward. And so, Dr. Shoge, I'm going to hand this question to you first. What do you think might be the next big step that you anticipate or that you'd really like to see for either policy or practice?
Yeah, there are a lot of big steps, so that I feel that we have the opportunity to take. So choosing, thinking about one was challenging. But I'll start off because I recently read that the APHA, the American Public Health Association Vision Care section, actually passed a policy statement in 2020 titled Increasing Access and Reducing Barriers to Children's Vision Care Services, which did outline action steps for federal, state, local, and community agencies. And so seeing what will come out of this policy statement, I think is going to be a big deal. So some of the items that were listed in this policy included directing public and private insurance for comprehensive pediatric eye exams. So really ensuring comprehensive exams. Screenings are good, but we have to educate people that it's just a first step in the journey of eye care and not the concluding step. Enhancing data collection, which we just talked about. Ensuring vision care services is a component of Medicaid, which is super important for kids and adults, so that there is this continuity of care, and also reinforcing that eye care is a major part of overall health care. For some reason, there's this perception that eye care is separate from the rest of the body, but it's very much an intimate part of our overall well-being. Increase access for underserved kids, especially at school and community health centers. Currently, when we look at the statistics in community health centers, 70% of those centers do not have an eye care person in place, no optometrist, no ophthalmologist. So that's a huge area that I think a lot of change could be made. We want to direct state and local authorities to encourage vision care for students with individualized education plans, or who have been identified with behavioral and learning disorders. So if some of these issues are coming up in school, that should really automatically trigger the teachers, the principals to educate the parents that they also need an eye exam. Because the research has shown there's a lot of overlap between uncorrected vision problems and school-based learning problems. And then encouraging collaborative response to educating parents on kids' vision care, which seems obvious, but we still need to work on. And then reinforcing sports eyewear considerations. And I'll add to that, it wasn't listed in one of their initiatives, but also screen time. I think we need to do a lot more research and a lot more education about the amount of screen time we're all engaging in, as we are now on this webinar via WebEx, and what we can do in terms of protective factors to make sure we can continue to have not just good quality vision and or not just good vision, but the quality of our eyes. We're comfortable with doing the different things that we need to do. So I think making sure that this policy statement becomes actualized across the nation, not just a state by state fragmented system, is certainly going to be important initiatives.
That was wonderful. Thinking about the breadth of what you mentioned, including the screen time, the integration with the rest of the healthcare system. And I know when we talk about access, we often think most about the affordability issue, which comes through the Medicaid. But you also mentioned things about just the basic availability of care and the awareness of the need for care that also affect people's ability to access care. Megan, how about yourself? What big policy or practice step do you think would be very helpful for this field?
Ruth gave us a really comprehensive list, and a lot of, we have a huge runway of opportunity ahead of us. I think I would start back at the beginning, which is that I think, for many of our populations, vision screening is the fundamental starting place. But I loved how Ruth kind of captured it. It's not the end point, right? If you get a vision screening, it doesn't mean you're done. It means if you get referred, you need to get connected into the community. And what we see first is that, in high poverty communities, in communities of color, marginalized populations, high percentage of English language learning in the families, kids are not getting screened at the same rates that they may be in more affluent communities. So it's really important that we make sure that all of the kids are getting screened in the first place, because that is honestly sort of the first connection into the system. But at the other side of that, we know these significant barriers to kids actually getting into care if they've been referred for a vision screen. And part of it is insurance, but there are a lot of other barriers too. So I think having policies and practices that support alternate models of care delivery that are not, again, that example of people having to come into the hospital in the clinic setting to see me versus what I learned from the Baltimore Reading and Eye Disease study of going into the school setting. And now, my team, as well as others, I see Sandy Block is on the call too, in Chicago. A lot of people have really built on this model of school-based delivery of care. And for more straightforward things like refractive error, kids who need glasses, these programs can be transformative. They are bringing the eyeglasses that are not only helping them see better, but learn more in school directly into the school setting and cutting out sort of all of those challenges. But that may not be the only option, right? There are certainly thinking more about our FQHCs and our other community-based programs. How do we harness bringing an optometrist or an ophthalmologist in part-time to connect kids with care more in their community than we currently do? I think will be really valuable to narrowing some of the health disparity gaps we see right now.
That's great. Of all the things that you said, when you said screening is fundamental, it made me think back to a program from some of our childhoods, RIF, or reading is fundamental, and how simple that might be as a marketing ploy to get people to realize the importance of vision screening, if somebody wanted to play with that a bit. Stephanie, how about yourself? I mean, I would imagine it's more the policy side than the practice side, that you might have a vision of how policy changes could affect the needs for your sons or parents like you. But what would you think about this question?
Well, as both of you have, stated, there are so many policies and so much work to be done. And so, I chose one, and I have to echo the importance of vision screenings and having that be the first step into the system. So, a couple statistics. One of the most alarming things that I learned when I was doing Eyes on Capitol Hill was the differences between the different states on vision screening requirements for school age and preschool kids. I mean, only 54% of states require vision screenings for preschool kids. Only 78% of the states require vision screenings for school-age children. And that may seem high, but when you really look at it, some of them require it once or twice in an entire 12-year, school career. And 10 states require no vision screenings whatsoever. And I was really sad to hear that my home state of Wisconsin is one of those. And so then it's up to other organizations to fill that gap. And obviously a lot of holes kind of exist. So, in my mind, I can envision all the kids of whatever age going without these vision screenings, and all those children who have potential vision problems that go undiagnosed. And then all those undiagnosed children whose learning and academic performance is at risk. So I thought I'd share my experience a little bit. So Brandon's preschool did participate in volunteer preschool vision screening program that was offered by a local chapter of Prevent Blindness. And so that's why I believe his teachers were so adept at identifying a possible problem. And so we were very fortunate that they did, even before we identified it. However, between kindergarten and grade 12, neither of my boys ever had a vision screening in school. And I didn't even know that was something that existed in other states. So sadly, we know that there's so many health inequities in pediatric eye care, but having all the states required to do preschool and school age vision screenings could just prevent exponential vision loss and preserve so much sight. And it makes me think of the saying that 1 ounce of prevention is worth a pound of cure, because really, how true is that?
Evan, could I just respond to one thing Stephanie said there?
Of course.
Because I just thought it was so important, and we've managed to go through 37 minutes without talking about the pandemic, but I will bring up the pandemic. One of the really startling things is, in addition to Stephanie's statistics and the example of her son who had a vision screening in preschool, but not after that, is we've seen a huge disruption in any school-based vision screenings during the pandemic, because schools for, the spring onwards of 2020 and a lot of 2020 to 2021 were closed or hybrid. So any of those screening programs were often disrupted. About 50% of states, the programs were modified or suspended entirely. So if you have a state, and I'll use Maryland as an example of the state, the program was suspended and your child was in first grade, if the gap in the screening requirements of the state are that you don't get screened again until 8th grade, we risk that kid then now has a 6-year gap before somebody will recognize a vision problem.
Yeah, that's it's very important, and certainly thinking about the variety of things that can disrupt school-based programs can be critical. With that point, and how the lack of access can be so important. Dr. Harewood had actually put a question in the chat, which I think it's useful to jump to. And certainly if anyone else has questions, we've got a couple more questions that we were planning to talk about, but feel free to put them in the chat as well. But I think that Dr. Harewood's question is actually quite relevant in light of the disruption from COVID. And her question is, do you think that telemedicine or technological advances has a role to play in increasing access to the pediatric population? And maybe Megan, since you had talked about disruptions, do you think telemedicine or other technological advances could have helped during the pandemic or even in general?
So yes and no. I think it's important when we talk about telemedicine, there certainly is a role for it. It's more challenging in the world of, I think, optometry and ophthalmology in terms of doing an exam via telemedicine than perhaps in some areas of medicine. But, we used it at Hopkins. Ruth, I'm not sure if you guys used it during the pandemic, but it was actually a really helpful way to stay engaged with some families. I think there's 2 important considerations. I actually am a big proponent of bringing telemedicine into school-based vision programs as a way to actually engage with parents, because one of the things that I always struggle with school-based programs is that parents aren't around. And I'm sure Stephanie can attest and Ruth can attest, there's something that happens in that dynamic of a conversation between the provider and the parent. And you can tell if there's a disconnect, or there's concern about wearing glasses, there's a concern about vision that you, as the provider and parent, can talk about together, that sometimes is missed in the school-based program. So I would love the idea of bringing in a Zoom or a FaceTime conversation that you could talk to a parent after you just give their child glasses. You don't need to bring them to the school, but that would be a nice addition. The one thing I do want to point out with telemedicine, although I think there are a lot of positives to it, I also think one of the things we learned during the pandemic is it also sort of widened pre-existing health inequities in some ways, and individuals who, either because of lack of access to technology or lack of familiarity with technology, were often the ones less likely to use it. So I think it can be a bridge. I still think there's some limitations that we need to figure out how to address.
I think your response was quite critical for helping us to remember, for those who didn't have this in mind already, that we're not just talking about exams, but your point about ways to include parent in the discussion sooner rather than later. The kid doesn't need to take a note home to the parent to then get back in touch. Let's just include the parent now when the technology is available. Ruth, how about yourself? Any insights on the telemedicine or other technologies, how that could help your practice?
Yeah, I think all the points that Megan mentioned were really important. And one comment triggered me of, when we bused the kids at my previous institution to the school for an exam if they failed their vision screening in the school that we administered. So that was at least a good first step. And then having, not many, but just those one or two situations where I can't in good conscience send the kid back to school on the bus because I've just found a tumor in the back of the eye or something pretty serious. And now we have to find the parent, get them to, the Eye Institute and then to the hospital for the next step. So having the technology to be able to include the parent in this sort of exam when they're not present is, I think, really going to be so important for the future. And, with the role of telemedicine, which we of course saw get a boom because of COVID, and it also highlighted, I think, how we're a bit behind, I think, when it comes to telemedicine in eye care. I think there are some inherent issues that we need to solve to make the experience a little bit better, both for the provider and the patient. But I think it's something that we should definitely harness and be at the table when it comes to technological advances in healthcare. And so I don't think we're really envisioning and using the full scope of technology to everyone's advantage. Even when it comes to education, everybody is on their phone or some kind of laptop or something. And so even pushing out educational material on social media, who in the next generation is going to do the TikTok on eye care and just, different things of that nature, and maybe thinking about it more full scope. The exam component is a big part of it. And again, I think we have some ways to go in technological advances in eye care to really make it full scope. But the educational piece is going to be as important as the interventional piece. And, a note about equity, I think at the beginning of the development of any technology has to be equity at the center of it, because, technology doesn't fix equity issues. People like to think it will, particularly tech people, like, oh, we have this technology, now everybody can have access to everything. And we've seen the opposite happen. So at the center of technology has to be equity, and people like us who are, who care about these things have to be part of that conversation.
Thanks. That last point is absolutely critical. I know, we talk in our business school about, how to drive innovation, and remembering that, that we get to choose what are the goals of innovation. And your point is a good reminder that increasing equity should be one of the primary goals of any further innovation in this area. Stephanie, how about from your point of view as a parent of patients in need of care, what would telemedicine or other technologies, how would that help you?
I was sitting here listening to all the comments, and I don't know how telemedicine would have helped. It would have allowed me with Hunter to have some sort of touch with the physician sooner than I did with his annual, his appointment that we take him to every year, which was delayed because offices were closed and everything else. So I suppose telemedicine would have allowed us a touch point to potentially, address any concerns. However, I don't know how well telemedicine in ophthalmology or optometry can be used for any sort of diagnosis or meaningful, clinical types of skills. So while I think it has its purpose for a number of ways, maybe not for diagnosis, but for even communication, I think we have to be very mindful about how we do it, and also and for it not to become the only option, because it can, by the very nature of having to have the technology to use, exclude a lot of people. So I think it will, as the field continues to develop, I think we'll find helpful ways for it to be integrated. and hopefully thoughtful ways for it to be integrated to help both the clinicians as well as the families and people that need the care.
That's
Kind
great.
of a follow-up to that, if I may, Kevin.
Yeah, go right
I
ahead.
think when we think about telemedicine, we shouldn't only think about home-based telemedicine. So telemedicine can certainly be full scope. It's really receiving care outside of a doctor's office, essentially, or a hospital setting. And so some of the technology that we are seeing as an example are retinal screening machines that are now you don't have to go, to the eye doctor to get that done. You can go to the Walgreens. So in terms of the placement of technology, it doesn't all just, we shouldn't just think about it as a home-based arena. Can I go to my Walgreens, my CVS, other community, health care folks that are cropping up. There are nurses in these places now. And so is it a matter of training more technicians who can administer this type of tech care, if you will, and then they're going to naturally be in touch with or assigned to specific doctors who then interpret that information. And so in terms of catching disease, is that an opportunity to catch disease faster because I can just walk into my CVS, get this retinal screening, and then that perhaps starts the conversation and the ball rolling a lot sooner than waiting sometimes 2 months to even get in to see your provider. So I think thinking of more broadly about what telemedicine looks like is also going to be an important part of these initiatives.
I would just add on, Ruth, because I totally agree with you. But one of the other things that is important, back to the policy question that Kevin asked all of us, is that there was a huge relaxing of telemedicine policies for insurance coverage and billing during the pandemic that has gone away. So my ability as a provider in Maryland to offer telemedicine services to other states has changed very much. So I think with developing technology in an equitable fashion, at the same time, we also have to think about the policies around billing and reimbursement for it, because I think that's a lot of what incentivizes hospitals and healthcare organizations to prioritize the use or just basically abandon telemedicine entirely.
Yeah, that last point is quite important. Where does the money flow, and how do we use that to drive equity rather than, there are probably some states where it would be more available than others, and we could, just at a different level perhaps of equity, but nevertheless end up with just as much of an equity problem. And it's interesting hearing the combination of responses, thinking about, changing the range of places where care could be administered, changing the initiation of communication with parents, and particularly to Stephanie's point, changing the continuity of communication with parents, and even if the actual diagnosis is still something that's going to need to be done largely in person for the foreseeable future. We've got a couple other questions in the chat, and don't want to sort of mix those up with what we've got. We've got two of you who are involved in research. Is there like one quintessential seminal report or other evaluation of the literature out there that would really help us to understand about school screening programs in particular?
Ruth, do you want to go ahead, or do you want me to jump in?
You can feel free to jump in. I was trying to think if there's just that one touchstone report. What do you think?
Yeah, I was thinking the same thing. So I think there's a lot of great data to the question about the ability to reach kids in school. So it's an obvious, easy place to do screenings. I think we have a lot of data as well about if you get into sort of high poverty communities, whether it is Detroit, it's Southern Florida, it's Baltimore, Maryland, it's Philadelphia, you have incredibly high failure rates. In our work in Baltimore, it's 1 in 3. kids in Baltimore City public schools between pre-K and 8th grade are failing a vision screening. And that goes up as kids get older. And to Ruth's point, we're seeing it a lot more with all the extended screen time, as we're seeing an increased kind of spurt in myopia across the country, as we've seen, internationally. So I think there's good evidence to demonstrate that delivering vision screenings in schools is important and valuable at detecting kids at risk. What we still struggle with, and which is why I think school-based vision programs have developed, is getting those kids who don't pass screenings into care in the community. There's also good data that disadvantaged kids are the ones who are less likely to get follow-up care. And there's reports of anywhere from like 95% not getting any follow-up care to the upper end, the better end is 50% getting follow-up care. But there's just these huge gaps.
Ruth, anything to add?
Yeah, I don't think so. I think, Megan, you summarized that well. And I think this really goes back to the data conversation we had earlier, is, where some of the contention of, do we really need to have these school screenings? I think the divide is that we know they're effective in catching vision disorders that need to be treated in a timely fashion. So we know that's good. And I think where maybe sometimes some of the consternation comes from is, well, if you're not doing anything, then what's the point of having these school screenings? So again, that's where we've done a great job of collecting the data, but then it's really translating that into providing resources for the community to then be able to follow up with comprehensive eye exams, get any glasses, surgical procedures, non-surgical treatments that are needed to actually fix the issues that we're catching in these school screenings. So I think when folks are having this conversation and reviewing the literature, always, have the question in your back of the mind, great, we have this information. What have we done with this information, and how have we turned that back over to the communities that are serving? So in short, they're good and they're necessary, but the follow through, I think, is what's we need to put an eye to.
Yeah, and that's something that's critical in the U.S. and all around the world. If we do all this work and we identify the kids, then what do we connect them to afterwards in order to make it have been a worthwhile investment of time and effort and better information for the kids and their families? We got another question. Would an increase in local vision care advocates help with DEI challenges, especially with respect to mobile and school-based exams? And, Stephanie, given your participation in Aspect and thinking about advocacy, how do you think an increase in local vision care advocates might help with DEI challenges or otherwise?
I mean, obviously, the more participation you have from local advocates, the better. I mean, it's never going to be a negative thing. I'm thinking, so I did vision screenings for Prevent Blindness Wisconsin in preschools for probably 5 or 6 years now. So we're a group of volunteers that, contact preschools, see if they're interested in vision screenings, and if they are, set them up and conduct them. So there's obviously, in certain states, a huge need for kind of grassroots efforts to fill a lot of the holes that are there. So I would never say that, fewer advocates is a good thing. I think obviously the more involvement, the more advocacy, the more issues are brought to light in whatever the community is, that's always going to hopefully reap benefits in the long term. So yeah, I mean, I don't think I could argue that it's not needed.
How about for either of our two providers, any thoughts on where local advocates might be most particularly useful, or which of the diversity, equity, and inclusion issues that we might think about would be most important for advocates to take up?
Well, part of community-based participatory research and follow-through is involving advocates at an early stage. And the thing about research and anything else that we do with the research we gather, or with the information we gather, is that advocates have already known what the issues are before academia does. And so making sure that they're really helping to drive the train in the dissemination of information, in the gathering of the information, because they're going to be the trusted sources within a community. You know, if I walk into a community, they don't know me. We have to establish a relationship, establish and build trust, you know, prove that I and the entity that I represent are trustworthy partners in these different initiatives. And that takes time. The advocacy workers have already done that work because they are part of the community. And so having their buy-in and having them at the table at the beginning of this work is going to be vital for success. So, you know, having Stephanie's had all of these conversations is going to be vital for success, because Stephanie already knows what the issues are from personal experience and from working intimately with her community. So we really shouldn't separate the two, and it certainly shouldn't be an afterthought on when and how to include community advocates.
Thanks. And that's, again, the importance of the community-based participatory research and involving people earlier. And I like your phrasing. The advocates know the issues before academia does. And that's almost always true. They probably have some great ideas for solutions already. And, you know, we may need some evidence or data to help convince the policymakers. But yes, the local advocates are critical for that. Megan, anything that you'd want to add about local advocacy?
So I would just underscore everything that Ruth and Stephanie have already said on this point. You know, and Ruth made that really critical, underlying the concept of trust, right? So if I go into a school and, you know, do an exam and send a letter home to a parent that says your child needs an eye exam or your child needs glasses, they don't know me. They don't know anything about me. And they may not even be aware of anything about an eye problem. They may never have worn glasses themselves. So there's sort of this education piece, there's the trust piece, and then there's who is this person providing care to my child and why are they doing it? And I think, and it's, again, I think we have to be very careful of any sort of top-down approaches that we think, oh, there's big, you know, access and health inequities in pediatrics, so we're going to come in as academia or researchers and we're going to fix it. You have to go into a community and listen to what's going on in the community and listen from their perspective about what's working, what's not working, where do they see the challenges, and build a relationship with them and honestly win them over to be your advocates and explain sort of the purpose of, if you're, you know, hoping to conduct screenings, you're hoping to conduct eye exams, learning from them where to integrate yourself into the system. And I think that builds bridges for the kind of strongest and most sustained types of programs. And also, you know, with these programs, I always worry that they're sort of these moments in time. And what we really need is to make sure that parents are educated and their children are educated to know when they need to see eye doctors on an ongoing basis. And so that we sort of build that trust and that educational awareness that they can then harness and advocate for themselves, even when they are outside of that certain opportunity.
And listening to the comments about trust, I mean, it comes back to, it touches back on so many of the other things. Without the trust, can you deliver telemedicine well? Without the trust, how does working in the schools work? Without the trust, how do you share data and how do you get them to, you know, make sense of the data or help them make sense of the data because they trust your judgment? And so, you know, that seems like something that would be critical for furthering access to and utilization of care to decrease the inequities as we move forward. A few other questions along the way. We have a little bit of time left. Another question that came up on the chat: discuss the ways that vision health of parents and caregivers can be addressed as part of children's eye health. Often, if parents perceive they cannot access eye care for themselves, they're less likely to take their children for eye care. So this is a family unit issue and how we go about addressing that. And Ruth, why don't you take that one on first?
Sure. It's interesting because I've seen both ways where parents bring their children in, especially the very young children, I'm talking under the age of 1, in early for their first eye exam because they had a problem as a child with their eyes. So they're already kind of attuned to, oh, let me make sure I take my child in early for an eye exam because I also had issues. So I've seen that side, but I've also seen the side where parents completely forego their own care, but they make sure that their children are coming in for exams. Sometimes the insurance coverage is a little bit, particularly for public insurance, is a little bit better for children than it is for adults. And so fortunately, again, a lot of this I think helps with education, education the public about the need for eye care, that we bring the kids in, and then subsequently when we see the good job that we do with their kids, we encourage them to get their eye exams, and now that the parents are also getting their eye exams. So I've seen both aspects, but I think it goes without saying that proper healthcare generally starts with the parents. You know, if they're engaged in the healthcare system, if they know how to navigate the healthcare system, which is a whole conversation in and of itself, then they're more likely to bring their children into that system from an early age. And so, you know, yes, if the parent cannot access eye care, it is more likely that the children are subsequently not going to be accessing eye care or healthcare generally, even if that child may be covered, because again, sometimes their coverage is a little bit better than for the parents. So I think education just really can't be underscored enough in these conversations, with letting parents know that, you know, to bring their kids in. I think a lot of that can happen at the school level, which is why we keep talking about schools, just because there's a consistent point of contact. You know, if kids are going to schools every day, if we educate the teachers, if we educate the principals, better yet, if we have the nurses, if there are still nurses in schools, because a lot of schools now no longer have nurses. I mean, this is an all-around healthcare issue that we're having, but the more information that we can provide to these key points of contact, the better it is going to be for the child and oftentimes also for the parents.
It is quite important for the parents to be able to navigate the system themselves, and whether they are motivated because of their own issues or just know that they should, and it's the kids' access. Stephanie, how about yourself? Either in your family or other parents you've known, has there been an issue with, you know, the parents' ability to navigate the system and what they know about the system and how that helps them or hinders them from accessing care that their kids need?
I think unfortunately, that because of the way that vision care is classified as its own type of insurance, if you want to say that in the States, and that it's not included in, you know, wellness visits as part of our health care, I think that it can very easily become an afterthought especially for people that have no relatives or no family experience with any types of vision issues. I think it's easy to forget, oh, maybe I should have my kid's vision tested, or maybe I should have my vision tested. You know, when we talk about advocating for different things, there are innumerable things obviously to advocate for, but one of the things I also feel strongly about is having vision services be part of a healthcare benefit, and have it be part of an essential service, just like you have an annual, you know, visit. Why can't we have an annual vision exam? That won't answer obviously treatment and other things, but it should, in my view, really be a basic type of service. Just like I believe the Affordable Care Act for kids, at least, has made that an essential service under their healthcare benefit. It's also easy as a parent to be concerned about your kids and put yourself on the back burner. You know, as soon as I found out about Brandon's vision, you know, it was all you thought about and all you kind of dealt with. It made me seek vision appointments for Hunter much earlier. But to be honest, even though, I mean, my husband and I go for vision appointments, so that was part of our of what we did anyways, but it's easy to put yourself on the back burner as a parent and to concentrate only on your kids. It's actually something I had never thought about. Is there a delivery model where you can have the children being screened as well as the parents? I think it's got some really interesting possibilities, and you know, that could exist there.
Thanks. And Megan, I don't want to cut off any comments you might have, but I do want to touch on all the questions that we've got. So I'll turn it to you to answer either A, if you have anything else to add, but B, one question that appeared on the chat. Are there any particular sources of funding or anybody we should go lobby or advocate to help fill in the research gaps in terms of getting the money to do the research that's needed?
Well, I would honestly love a research study that talks about exactly what Stephanie just talked about, demonstrating the impact of delivering care to a family unit, and not just kids through a school-based program, and not just adults at a community screening, but actually having an opportunity to demonstrate, you know, how do you do that? What's the implementation science side of it? And what is the impact, not only for the improvement in vision, but also maybe the long-term likelihood of utilizing care, because they are being sort of educated as a family unit about vision and eye health. So one of the things I will say is Dr. Michael Chang, who's now head of the National Eye Institute, put out the NEI priorities last year for the next 5 years, and health equity was one of the core categories of priorities for the Institute. And I thought that was incredibly important to, you know, have on this national platform how important it is for us to be thinking about issues of health equity for adults and kids. And I think that that is invaluable in thinking about it as a funding priority, not only for federal funding from NIH, NEI, but also from other foundations and local philanthropic organizations as well, because they sort of often take their cues from what they see as national funding priorities. I would just add one final point to the sort of question about parental experience. One of the things that I have found that's really important, and you've heard this from everybody already, parents' experience very much influences that they've had glasses, so they think their child should get checked from glasses, or they've had perfect vision, so they can't imagine that their child happens to be a 5-diopter myope. But what's also important is parents, and of my generation, I can say this because this happened to me. I was teased a lot as a kid when I wore glasses, and that's not the case now. Certainly not as much as it was. Glasses are actually often a fashion statement. But I have had parents be pretty upset about their child getting glasses and not wanting them to wear glasses because they recalled what it was like as a child. And glasses were not as attractive back then. They were not as fun. They weren't as cool. So I think that's also an important thing to consider, is if they had some type of negative experience like that, that may also impact their likelihood to bring their child or even encourage them to wear their glasses.
I certainly, I always comment that even at my 20-year high school reunion, which was now 15 years ago, somebody said, "Oh, you're not Four Eyes anymore," having just gotten contacts. And I'm like, didn't we leave that in the 80s where it belonged, to the degree that it ever belonged? But yes, it is something that people of our generation would still be sensitive to for their kids as they age into needing glasses when that occurs. We have just a few minutes left. Stephanie, any final big picture comments or observations from today, or just thoughts about, you know, what do you see as most important on the horizon?
So I am just, you know, the more I advocated for years, and I still do, for my children. I mean, it was a lifelong mission for me. But over the last few years, I've been fortunate to work with some other organizations and find a different voice and find a way to work towards change, all the changes that are needed, and to hopefully make a difference. And I have been most encouraged by all the organizations out there. I mean, I just can't believe how many there are and how they're involved in so many different ways. And I guess I would just encourage people to to get involved. All you have to do is reach out to any of these entities and they will provide guidance. They will give you opportunities to find what you're passionate about and to work towards those, making a difference in those goals. So, you know, wherever you are in your vision journey or however you are tied to that vision journey, I guess I would encourage people to get involved, find out the things that they really care about, and learn how to make a difference.
And I'll direct the same question to you, Dr. Shoge. Anything that you have as a big takeaway for all of us from today or just in general moving forward?
Yeah, I'm super encouraged that NEI has prioritized health equity research. So definitely thanks for sharing that, Megan. And what I really would like to see is optometry and ophthalmology moving and working together in the same direction, because we do have common goals, which is to provide the best care for our patients, period. So I would love for us to have a much more collaborative relationship so that we can amplify and multiply our efforts. I'm very much not into duplicating efforts. Why am I going to do something that somebody already did and possibly doing better? So how can we really work together to solve this public health crisis? So that's what I'm most looking forward to.
Thanks. And Megan, I'll pass it to you for any quick final thoughts.
Fortunately, Ruth and I totally agree. So we're demonstrating the easiness of collaboration between optometry and ophthalmology. And I think it goes broader than that too. I think we're really, you know, children in the US and I would argue globally are really at a kind of crisis point right now. They've had 24 months of disruption of their lives because of a pandemic that's caused substantial learning losses amongst our most disadvantaged students, as well as deterioration in health. And there is such an interrelationship of those two things that we risk a generational loss of kids if we don't work together and figure out how do we address their vision as well as their other healthcare needs, and how do we reimagine an education system that's going to give them a kind of more comprehensive, equitable access to the things they need.
Thank you. And I just want to draw us to a conclusion. I want to thank our three amazing panelists for providing us with some insights on things about the system, how they got interested, data that would help us to move forward, how specific pieces of technology might help us, and a real sense of how all the providers in this space can work together better. And as an economist who sat on the sidelines and watched this for the past quarter century, I could say it's certainly moving in the right direction, even if we're not quite there yet, as evidenced by my two colleagues today and many others. And I think a good sense of where we can go. And to Stephanie's point, you know, there are ways for all of us to get involved, to increase our involvement and to find organizations that can meet us where we are in our vision journey and help us to have an impact moving forward. The recording of this event will be available soon, as you can see at the bottom. And on October 13th, which is World Sight Day, we expect to have another event and additional webinars in 2022 and 23, sponsored by Vision 2020. So I want to thank everyone for their time this morning or this afternoon, depending on where you are, and look forward to seeing you in the future at future webinars.